Today's topic is actually it's an interesting case from neurology. My consultant of DIAB would be joining soon. It's I've just given him in heading like not a laughing matter. So the case, this patient was admitted to the Conquest Hospital. So maybe the medical team, a few of the medical team would know about this one. So the case, here is a 21-year-old male who is right-handed, not driving, who lives with parents, used to work as a scaffolder, who is a current smoker, who is known to have excess alcohol, but he claimed that he last had it 1 month ago, and he also reported some recreational nitrous oxide use 2 weeks ago. His past medical histories are he is an epileptic on lamotrigine. He had a recent episode of dislocation of right shoulder for which he had arthroscopy on 9th of December. He's not have any drug allergies. He had COVID vaccination 6 months ago. No other recent vaccines. He was admitted to the Conquest Hospital on 16th of December with the presenting complaint paresthesia of hands and feet and feeling unsteady for 14 days. Then it evolved and it led to weakness in both hands and legs, distal more than proximal and very clumsy, and he couldn't walk for 4 days. He denied any foreign travel or illness. On examination, his observations were stable. Other systems were within normal limit. His neurology examination, it showed intact cranial nerves, no facial asymmetry or extraocular movements were normal. Motor examination, his bilateral upper limb power 4/5 proximally and 3/5 distally with glow and stalking pattern of paresthesia. He also had loss of vibration and position sense in upper limb. Lower limb, he had normal power globally with mild weakness in knee extension, and he got loss of proprioception up to knees. He had all the routine bloods and it was normal except his vitamin B12 was on the lower side. It ideally should be more than 200 and his was 132 nanogram per liter on 16th, that's the day of its admission, and the next day it was 112. And the ward team has sent an extensive screen, including the infective, vasculitic, and autoimmune screen, and they were in back on this day. And he had a lumbar puncture and the CSF findings were normal protein, no albuminocytological dissociation or anything. He had a chest X-ray which was normal. I'm just thinking whether if you have any thoughts, maybe you can put in a chat. It's mainly someone who is coming with loss of vibration, loss of power problems like 4/5, 3/5 in the upper limb, loss of vibration and proprioception use, and proprioception sense, and with the history. If anyone wants to pop anything on the, oh, sorry, I've just showed it. So, no, there is no point in now then, I'm sorry. So the diagnosis is subacute combined degeneration of spinal cord secondary to nitrous oxide misuse. One of my colleagues have told me they have seen a few more other cases in the hospital recently. I'll just go to the discussion about this later. Next, we are just going to continue the case. So the pending investigations were back, and his homocysteine level was 30.1, which normal should be less than 15. Methyl malonic acid level was 699, which normally should be less than 280. And his vasculitic, infective, and celiac screen were negative. We have done an autoimmune screen with parietal cell antibody, anti-TPO, interferon intrinsic factor antibody, everything negative. His ESR is 7. So he had an MRI on the next day of his admission, which was MRI head was normal. MRI cervical spine on the same day showed long segmental signal abnormalities involving the dorsal column of cervical cord, that is C2 to C6, and which suggestive of subacute combined degeneration of the cord. And vitamin B, that's vitamin B12 deficiency, and they have reported as a differential should be nutritional or metabolic, copper in case it's copper or vitamin E, or substance misuse as nitrous oxide. He had a repeat MRI. It's not like a repeat whole spine MRI on 20th of December, which shows inflammatory and demyelinating episode in cervical and upper thoracic cord. So what we have done in the ward team has started on cyanocobalamin injection, 1 milligram IM injection, which was started on 17th. And it was administered every 3 days for a total of 11 doses. Then the plan was actually once weekly for 2 months, then monthly for 3 months, then every 3 months. During admission, he was reviewed by OT and PT, and they've arranged some equipment at home, and he was discharged on 23rd of December. And he was attended as tech on 24th for the next dose of cyanocobalamin. Thereafter, district nurses were arranged to administer in the community. And the patient was reviewed later in the next month in outpatient neurology clinic, and he reported that he had a good recovery over 3 weeks, and he was able to walk without wheelchair, but slightly unsteady on feet. Numbness persists, but no visual, bladder, bowel complaints. On examination, he was still having wide base stamping gait, and he was still having the reduced sensation in the upper limb. So the plan from the neurology clinic was to continue the B12 injection, and he was referred to neurophysiotherapy, and he's still waiting for a nerve conduction study. It hasn't happened yet. So a little bit more about the topic about subacute degeneration of spinal cord. It's a neurodegenerative demyelinating disorder secondary to vitamin B12 deficiency. The most important cause is nutritional deficiency. Mainly the cobalamin is found in animal food, so strict vegans are prone for this. Second one, gastric abnormalities. If someone who had gastric surgery or gastritis, what will happen is for the release of vitamin B12 from the protein-bound form in the diet, we need gastric acid and intrinsic factor, and it's been produced by the loss of it's been produced by the parietal cells. So loss of parietal cells can lead to vitamin B12 deficiency. Second one, autoimmune gastritis or pernicious anemia. That means it's autoimmune destruction of the parietal cells. Then small bowel disease like IBD, sprue, radiation enteritis, lymphoma, amyloidosis, SBO, and ileal resection all can cause vitamin B12 deficiency. Pancreatic disease can cause vitamin B12 deficiency because pancreatic enzymes are needed to cleave vitamin B12 from salivary proteins to transfer to intrinsic factor. Sorry. And the next cause is a fish tapeworm infestation. Usually the fish tapeworm compete with the host for the vitamin B12. And some genetic abnormalities like transcobalamin deficiency and a syndrome as well. And there was also reported a drug-induced vitamin B12 deficiency, mainly PPIs, more if the patient is using more than 2 years. And metformin, it's mainly by involving calcium-dependent ileal absorption of vitamin B12 intrinsic factor complex. So nitrous oxide, this is the cause that we have found out here. Recently, the study shows that it's like an epidemic. There is a growing incidence of people coming with neurological problems after the nitrous oxide inhalation. So nitrous oxide usually used for surgical or dental anesthetic or as an aerosol spray propellant or recreational use. Among abusers, usually it called as whippets, and users actually sometimes they will use multiple whippets because it's only have a transient effect and it's only last average of 30 seconds. So when it inhales in high concentrations, it can convert vitamin B12 from its active form, that's bivalent, to its inactive form, leading to indirect depletion of vitamin B12. So it's like a functional deficiency. And as I mentioned, over the past decade, it's been like a growing epidemic. And its main reason is there is ease of access to nitrous oxide. So we might be thinking why the vitamin B12 is causing the neurological problem, because it's mainly involved in the myelin production. I'm not going into detail of this biochemistry, but it just few things. Mainly vitamin B12 act as a cofactor to convert methylmalonic acid to succinyl coenzyme and homocysteine to methionine. So methionine is actually a precursor for adenylyl methionine, which is required to maintain the neuron sheath. And the succinyl coenzyme is necessary for the myelin synthesis. And when this step doesn't happen, the methylmalonic acid get accumulated, and that can cause the result in incorporation of abnormal lipids in the myelin, leading to demyelinating changes. So in our patient, if you remember, we were saying, I mean, like, I've just noted like that the methylmalonic acid and homocysteine were high. It shows that this pathway is not happening because of the functional deficiency of vitamin B12, and that can cause demyelination. So in history and examination, if you're worried, or if this is a differential, we should be focusing on identifying the underlying cause of B12 deficiency. The patient we need detailed neurological examination, and it probably shows spastic paraparesis, positive Romberg sign, and loss of vibration sense, proprioception, and 2-point discrimination, ataxic gait, and reduced sensation. Mainly, the demyelinating effect of vitamin B12 deficiencies on the dorsal column pathway and lateral corticospinal tracts. If the spinothalamic tract is involved, then it can cause sensory neuropathies in lower limbs. Next, investigations. First, the bloods. Mainly, we're looking for like macrocytic anemia, then hypersegmental neutrophils, then low serum vitamin B12. But it's not actually a reliable marker. Just as I mentioned, the metabolite levels like methylmalonic acid and homocysteine can be elevated, and this is actually we do for the confirmation. Also, we need to check folate levels because deficiency can mimic, and autoimmune screen because one of the cause for vitamin B12 deficiency is autoimmune, pernicious anemia, and definite diagnosis by MRI spine. And all what we used to see is like demyelination. It shows us a high signals. It's most commonly affect the dorsal column pathways of cervical and upper thoracic spinal cord. And that's what we can see here as a inverted V or inverted rabbit ear sign. I'm just going to go through some differentials as well. The first differential is actually nutritional or metabolic deficiency or toxicity. So other nutritional deficiency that can cause similar kind of neurological presentation is copper and vitamin E. Both of them can cause hyperintensity of dorsal columns and mimic neurological deficit. And but in the copper deficiency, copper deficiency usually can happen in people with a history of gastrointestinal surgery, zinc overload, or someone who is on parenteral nutrition, who is having malabsorption or malnutrition. But there will be always low levels of copper and ceruloplasmin. And one of the other blood is like myelodysplastic syndrome, and thus we can differentiate this from the subacute combined degeneration. This next differential is actually the demyelinating neuropathy, because this one is also demyelinating one. The first demyelinating differential is transverse myelitis, but what is differential is actually it usually does not affect the dorsal column, and it's always usually limited to 1 or 2 spinal segments. So when we do a gadolinium enhanced spine MRI, it can confirm the diagnosis by revealing enhancement involving 1 or more cord segments. The second one, the demyelinating neuropathy, is MS, but MS is always asymmetric and affects only a few segments. And also MS has its own peculiar features. It's distributed over time and space, and it will be having other specific features of MS. Then next is infectious. So one is HIV. HIV can present also with like symmetrical involvement of dorsal column and mimic like the histology MRI findings and the symptoms. But always we can look at the history of HIV or low CD4 counts or any evidence of opportunistic infections, AIDS, defining illness, or malignancy. The other infectious differential is actually tabes dorsalis. It also damages dorsal columns, and it can present as sensory ataxia. But the differential features is actually it usually involves a dorsal root, and there will be lancinating pain and a presence of Argyll-Robertson pupil and positive history of syphilis. Not a common one, but it also differentiates Friedreich's ataxia. It's an autosomal recessive disorder, and it usually presents with like impaired proprioception, vibration, or depressed tendon reflex. But it will be having its own peculiar features, including cervical cord atrophy or hypertrophic cardiomyopathy, nystagmus, and pes cavus. There are a few more differences that I haven't included. Some inflammatory conditions such as sarcoidosis, ischemic lesions, and malignancies. So the management, as we mentioned, is mainly the supplementation of vitamin B12, either in oral or the parenteral form. Oral is mainly if someone comes with dietary deficiency, will give the vitamin B12 as oral. But parenteral administration is for someone with severe neurological dysfunction and or symptomatic anemia or malabsorption disorders. The prognosis is usually good if we identify early and treated promptly, but sometimes the patient can end up with residual, long-term, moderate to severe neurological deficits, and it's especially seen in those who discontinue the treatment. I think that's it. That's it from my side. Thank you. If you have any questions, please let us know. I think my consultant is going to be here as well. Just stop sharing. I think that's it. I think no one has any questions. Anyway, thank you. Thank you for listening and have a good day.
Thanks very much.
Thank you.